Bismillahirrahmanirrahim. I'm Dr. Atika Masood, and today our topic of discussion is tumors of the liver. As you know, if we are going to classify the tumors of the liver, these can be divided into the benign ones and the tumor-like lesions and the malignant ones, and the last one category will be the metastatic lesions. And I have already told you people that the most important category in the liver is the metastatic liver carcinomas. If we are going to discuss about the benign tumors, then the most common benign epithelial tumors include liver cell adenoma, bile duct adenoma, bile duct cyst adenoma, and biliary papillomatosis. While if we are going to talk about tumor-like lesions, then the most important category is focal nodular hyperplasia. My dear students, you must remember that in BPH, benign prostatic hyperplasia, there is a hyperplastic component in the muscular region and in the glandular region, and the same thing is happening if in the liver. It is going to be called as focal nodular hyperplasia. We are going to discuss it in detail in our today's lecture. Then our next category includes benign non-epithelial tumors or the mesenchymal tumors. As you all know, the most important tumor which is going to be under the category of the mesenchymal tumor is hemangioma. So first of all, we are going to do the nodular hyperplasia. My dear students, as its name shows, that there will be the nodules formation, and in these nodules, in these regenerative nodules, we are going to have a hyperplastic liver cells. So these could be solitary or these could be multiple, but they are going to be very well demarcated. As you all know that well demarcations are the most important characteristic of the benign lesions, but sometimes these are poorly encapsulated nodules that are going to develop in a non-cirrhotic liver. Why we are telling this? Because in a cirrhosis we are already having a nodule formation. So this nodular hyperplasia has an importance because it is going to be developed in a non-cirrhotic liver in which there is a no regenerative nodules already present. The most common factor in both types of these nodules, whether they are going to be solitary or the multiple, seems to be either they are going to be focal at one area or they are going to be diffuse alterations in the hepatic blood supply, and they are going to arise because of the obliteration of the portal vein radicals, and they are going to be compensatory augmentation of the arterial blood flow. So there are going to be two types. One is going to be named as focal nodular hyperplasia, and the other category comes under the heading of this nodular hyperplasia is nodular regenerative hyperplasia. So first of all, we are going to discuss the focal nodular hyperplasia. If you are going to see and this picture, gross picture of the liver nodule, the most common finding that you can see here is this whitish fragment. Here I am outlining this our whitish fragment, and here you can see this is a very fibrotic, very well demarcated type of nodule that you can see here, and this is giving you a grayish white appearance in otherwise very normal looking liver. And if you are going to see under the microscope, here you can see that in this portal-triad area we are going to have some inflammation that is going on in this area. Here the inflammatory area, this is your portal-triad, and we are going to have all the areas of the inflammation. But here you can see that the normal arrangement of the array-like structure is lost, and we are going to have more than these array-like structures, and we are having the hyperplastic nodules. So the main etiology of this focal nodular hyperplasia is the long-term use of the contraceptive pills or the anabolic hormones. So it is mainly seen in the women who are using the contraceptives. And just remember this thing, that in a university question, mainly in the MCQs, this is always asked, that a woman is taking the oral contraceptive pills and now she is presenting with the nodule in the liver, which is not a neoplastic one. So what will be your diagnosis? So my dear student, the diagnosis will be focal nodular hyperplasia. Now comes our second most important category under the hyperplastic nodules, and this is the nodular regenerative hyperplasia. So we are going to have a regeneration type of thing that is going to happen, and you know that why this regeneration is going to happen whenever there is a problem with the flow, with the blood flow, or there is some problem with the injury of the liver, and because of the injury there is a loss of some cells, and because of the loss of these cells there is a compensatory regenerative hyperplasia. So liver entirely transformed into the roughly spherical nodules, but what is it is going to differentiate it from the cirrhosis? That in the nodular regenerative hyperplasia we are not going to have a fibrosis. So this thing is very, very, very important. Just remember, my dear students, that in a cirrhosis we are going to have a regenerative nodule surrounded by the fibrosis, or when we are going to stain it with the reticulin is going to stain the fibrosis. But if it is nodular regenerative hyperplasia, we are having only a regenerative liver cells, we are not going to have fibrosis. Microscopically, they are going to be, we have regenerative plump hepatocytes, and they are surrounded by the rim of the atrophic hepatocytes. So the hepatocyte that has been atrophied or destroyed are going to be replaced by the plump hepatocyte. Reticulin stain is basically required, that what I have just told you is to appreciate the changes in the hepatocellular architecture, and we are unable to see the fibrosis here in this picture. Then comes nodular hyperplasia can lead to the portal hypertension because of the excessive number of T cells. There is a pressure which is going to happening in the portal triad and the central venous area. So this is going to cause the portal hypertension, and it can occur in the association with the intrahepatic with the condition that is going to affect the intrahepatic blood flow. We are going to have conditions associated with it like transplantations, bone marrow transplantations, vasculitis, and HIV infected persons. Now comes our next category. We have just done the tumor-like lesions. Now we are going to start with the benign epithelial lesions, and the most important benign epithelial lesion is the liver cell adenoma. So my dear students, liver cell adenoma is mainly seen in the women of the childbearing age who are using OCPs, and you can see here that there is a liver cell adenoma. Here you can well appreciate it. It is very much well demarcated, and the problem with this is there is a risk of rupture, and as the liver is a very, very vascular organ, so there could be hemorrhage because of the rupture. So if you are going to see the picture, then this one is very, very important. Here this is the capsule. This whole lining is basically of the capsule of the adenoma. This is the capsule, and here you can see that these are having the adenoma-like hepatocytes which are increased in number, and they have lost the main arrays or appearance of the normal categorization of the liver, or which is the normal morphology of the liver has been lost. So first of all, the most important thing that we are concerned here is about the molecular genetics of the liver cell adenoma. So multiple hepatic adenoma, in which the syndrome can be called as adenomatosis, adenomatosis syndrome. If my dear students you remember, in a GIT chapter, gastrointestinal chapter, we have done the adenomatosis syndrome, familial adenomatosis syndromes in the small and the large intestine. So the similar thing can happen in the liver, and these syndromes can occur in the individuals with maturity onset diabetes of the younger region. So with the MODY3 and HNF1 mutations that are very important because of the germline mutations of the MODY3 with maturity onset diabetes patients, or the somatic mutations can cause the further next second hit mutations. So here comes the second hit mutations. This is your MOD1 is your first mutation, and if we are going to have HNF1 biallelic inactivation because of the use of some environmental factors like OCPs, as I have just told you that it is very common in the women, then this normal liver can change into the liver cell adenoma. And the most important thing that you have to remember is that if there is any other problem like transcription factor 1 mutation in the liver cell adenomas or other genetic mutations like P53 or other mutation, then these can convert into the hepatocellular carcinoma. So this adenoma carcinoma sequence is very important for you people to remember. Here comes the picture of the adenoma. Now we are going to start with the malignant epithelial lesions. First of all, if we are going to classify the malignant epithelial lesions, the most important one is the hepatocellular carcinoma. Then come hepatoblastoma, or round blue cell tumor, which is going to originate from the blast cells. And then comes the cholangiocarcinomas, bile duct cyst adenocarcinomas. And if we are talking about the malignant non-epithelial tumors, you have done in third year about the angiosarcomas. So the most important one is the angiosarcomas, and more than 90% of the tumors that are coming into the liver are the metastatic in origins. So remember this thing. My dear student, these 4 lines are very important for you people to remember, because normally these have been asked in your MCQs. Normally in the MCQs it has been asked that what is the most common benign tumor of the liver, and it is the hemangioma. As I have just told you that the most common malignant tumors of the liver are the metastatic carcinoma, which are the 90%. Then comes which is the most common primary ones. If they are going to ask you which is the primary one, but you should remember this thing. Metastatic ones are not the primary ones, these are the secondaries. So if we are talking about the primary ones, then the most common malignant tumor is the hepatocellular carcinoma. And if we are going to talk about the most common tumor in the young children, I have just told you it is the round blue cell tumor, which is originating from the blast cell. It is the hepatoblastoma. So today we are going to start with the hepatocellular carcinoma. It is mainly the most important carcinoma, as 5% of the all cancers, 5% of all the cancers in the world is included in this picture, and the most common cancer in some area. There is a marked geographic distribution, and 85% occurs where hepatitis B virus is endemic. So this is the most important thing, and very sadly nowadays hepatitis B and C is spreading like anything in Pakistan. So the constant risk factors include male gender, age, so age older than 50 years, cirrhosis which pre-exists, like if we are talking about hepatitis B and C, so because of that it can have cirrhosis, or because of the alcoholic cirrhosis, cirrhosis exists in 85% of the cases in Western world because of the alcohol. So this is also an important risk factor for the production of the hepatocellular carcinoma. Then the most important one is the environmental factors, like I've just told you, hepatitis B, hepatitis C, aflatoxins. You must have read in the carcinogenesis chapter that the aflatoxins, which is a fungus which is going to be called as Aspergillus flavus, is the most important thing that can cause the hepatocellular carcinoma. And then comes your inherited conditions like hemochromatosis, tyrosinemia in the children. If we are concerned with the gross morphology of the hepatocellular carcinoma, then my dear students, just remember, liver is a very, very smooth or a soft type of having a rubbery consistency of the normal liver. And in this hepatocellular carcinoma, we are going, if this is your liver, we are going to have multiple nodules, or sometimes we are going to have solitary mass, or sometimes it is a very diffuse one. So it has a propensity for the vascular invasion, and that is having a very worse prognosis. So vascular invasion is having a worse prognosis, and when in MRI we are talking about the vascular invasion, so the chances of good survival is very, very less. It is going to form the trabeculae of the malignant hepatocyte, but there are many patterns which we are going to discuss just right now. And then it can spread to the regional lymph nodes, lungs, and then into the other areas. The most important findings in the serum, which is the non-invasive one, is the raised serum alpha-fetoprotein levels. But as you know, that is not a very specific marker, because there are other conditions like in pregnancy, like in spina bifida, like in testicular tumors, serum alpha-fetoprotein levels can be raised. So it has going to have a very extremely poor prognosis, and the best prognosis of the variant that it has is a fibrolamellar carcinoma, which is a variant of the hepatocellular carcinoma. And as you see here, we are going to discuss it in few minutes, that it has a fibrotic element, and it can this fibrosis can prevent the spread of the tumor. So if we are talking about the pathogenesis of the hepatocellular carcinoma, what is going to happen, that I have just told you that there are the most important etiology is the hepatitis B virus and the hepatitis C virus. So there is, because of the infection that is going on here, there are lots of cytokines, there are lots of inflammatory reactions that is going to happen, and because there is death is going on, there is a war going on between the cells of the body and these foreign viral particles. So there are the repeated cycles of the cell death and the regeneration, and because of this, cell cycles can accumulate mutations and eventually transforms these cells into the hepatocytes that are going to have mutations in it. The most important one, if we are talking about the hepatitis C, is hepatitis C virus and NS5A domain that is going to participate in the development of the hepatocellular carcinoma. If we are going to talk about aflatoxins, which is a fungus produced by food spoilage molds, the most important thing that it is going to cause, that its product is going to come within the DNA, and they are going to form the mutagenic adduct with guanosine. So when it is going to form the adduct, aflatoxin is going to form the adduct with guanosine, it may cause guanosine to thymine transversion at 249 codon of P53, which is a tumor suppressor gene. And when this tumor suppressor P53 is got mutated, then it is going to lose the role of tumor suppressor genes. So as you know that P53 is a guardian of the genome gene. So when there is a guardian of the genome gene itself is going to be mutated, then there is no inhibition for the tumors to grow. If we are going to talk about it, hepatitis B virus infections and aflatoxin exposures and genetic variations, then there are going to be increased risks for the hepatocellular carcinomas. As I have just told you that in hepatitis B there is a repeated cycles of the cell death and regenerations, and because of this there is a genetic mutations that is going on because of the continuous regeneration that is going to happening. And the most important thing that is very important, we have already done in our third year, that is the hepatitis B virus X protein. So this regulatory element is very important, as it is going to cause the mutation during the transcriptional levels, and these are going to cause the hepatitis B X virus protein disrupts the normal growth by activation of the proto-oncogenes, and these proto-oncogenes of the host are going to convert it into the oncogenes, and then these oncogenes production can cause the oncoproteins levels, and these oncoproteins can cause the clone formation of the cells that are going to be malignant. So some hepatitis B virus proteins can bind and inactivates the P53. So again, if there is no P53, there is no tumor suppression that is going to on, and also there is a formation of the oncogenes and oncoproteins. So there's a whole environment in which we are going to have mutations because of the regenerative processes, and because of all of these transactions, mutations, there is a formation of the hepatocellular carcinoma. If we are talking about the genetic alterations, the most important pre-mesoplastic changes that can occur recognized morphologically is the first thing that we can recognize is the hepatocyte dysplasia. Like any other tumor, this dysplasia is very important, and progression to hepatocellular carcinoma can result because of the mutation, as I have just told you about the P53 KRAS level, because it is very important in the nuclear transcription factors. Then c-MET, again a nuclear transcription factor, c-MET a nuclear transcription hepatocyte growth factor, TGF alpha trans growth forming factor alpha, and insulin like growth factor, because whenever there is an inflammation going on, TGF alpha and IGF is going to be secreted, and in the repeated inflammatory cycle these are going to be very important, and then there will be the activation of the WNT beta catenin pathway or AKT pathways, and then the whole signaling pathways will be mutated. So if you are going to see the gross picture of the liver, here you can see that this liver has been having the multiple nodules. I'm sorry, this is going to have multiple nodules. Here one nodule, second nodule, third nodule, fourth nodule, and you can see here it's a very vascularized type of thing. So I've just told you that these nodularity is not of the cirrhotic, because in cirrhotic liver there is a fibrosic appearance, there is a grayish appearance. So we are not having any grayish appearance. This is very much fleshy type of appearance. If we can see here, this is your hepatocellular carcinoma. And why I am telling you that this is a hepatocellular, as you can see, tell me that, ma'am, this is having a very good capsule, but if you are going to see this area, so we are going to have multiple areas, but that I have to telling you, okay, there is a multiple area. On appearance it seems like that there is only one nodule, but if you are going to see it clearly, there are multiple nodules which are going to be involved here. So if we are going to see, we are going to have a plump hepatocytes which are going in a disarray forms all over this. There is no portal triad, as you can see in this picture, and the sinusoids are all very congested. Here this is the sinusoid, these are the trabecular formations or the rods formation, and sometimes in a high grade tumor this is some type of glandular formation. So we can have multiple types of areas. Here you can see in a much higher picture that you can see there is a dilatation of the sinusoids, and we are having these cells which are highly pleomorphic, and these are having a prominent nucleoli. If, my dear students, you can see here that this is the prominent nucleoli, again a prominent nucleoli. We are going to have mitotic figures. So we are going to have a highly pleomorphic types of cells again in this picture. And then this is another picture. Here you can see that there is a globules of the bile can also be seen in the cytoplasm of some cells and in the between the pseudocanaliculus that is going to be formed in between these cells. And we are going to have acidophilic. This is your acidophilic hyaline inclusions within the cytoplasms. Again, acidophilic cytoplasmic hyaline inclusion here are also present again, and other inclusion is present here, and it is going to resemble the Melry bodies. And scanty stroma is the most important categorization of the hepatocellular carcinoma, and because of the scanty stroma, it is giving you the soft consistency of these tumors. And now this is the most important one that we were talking about in the first or second of the slide. Here you can see that this is a tumor. It is not very well marginated as rays are originating from this. Here you can see again, here you can see again this area. So we are having multiple areas, but it is not a very soft consistency. And why it is not having a soft consistency? Because you can see that there are lamellar-like fibers or fibrotic band that are going on, which were not there in the previous pictures. And in these fibro, so this is the important variant which is going to be termed as fibrolamellar variant, which is having a very good prognosis. And within these fibrotic bands, we are having the plump hepatocytes. So dear students, if you can see here, I have just told you that there is a high percentage of formation of the hepatocellular carcinoma in the already cirrhotic liver. So if you can see here, this is a very good picture that this is your hepatocellular carcinoma nodules that is going on. And if you can see here, these are your very much normal cells or cirrhotic liver cells, which is the regenerative nodule. And if again you are going to see this picture, this is carcinoma. This is carcinoma. This is regeneration. This is again a carcinoma. This is again a carcinoma. Again a carcinoma. So we could, and all around here we are having the fibrosis. So if there is a cirrhosis, pre-existing cirrhosis, and there is a formation, so you have to differentiate between the cirrhosis and the hepatocellular carcinoma foci. So the important ISC that we are going to use for the hepatocellular carcinoma is the glypican-3 that is being used. This is very important. You should all know that for the immunohistochemistry, the marker that we are going to use for the identification of the hepatocellular carcinoma, whether it is a metastatic one or the primary one, that is the glypican-3. Then comes prognostic factors, or that why death is going to occur in the hepatocellular carcinoma. It could be because of the cachexia, it could be because of the esophageal varices, or the bleeding that is can pre-exist because of the cirrhosis, or liver failure, hepatic coma, or anything like that, or rupture of the tumor with fetal hemorrhage. So in our next lecture we are going to do the bile duct. So for today your homework is that you have to write down the classification of the hepatic lesions, and along with the attendance you have to submit the hepatic lesions classification. If we are talking about the hepatic lesions, it includes benign lesions, it includes regenerative lesions, and it includes malignant ones. So while writing the classification, just remember this factor. Thank you very much for today's lecture.